We need to think about using the triangle of triage to proactively trigger bladder health baselines with a minimum of cystoscopy up to a maximum of multi-channel urodynamics. The right data, the right dialogue dictates the right deobstruction at the right time when warranted. Triggers include reporting urge incontinence, spontaneous retention, IPSS 8 and above alone, or in combination with lower flow, higher residual, thickened detrusor, or unacceptable risk on bphtool.com. Before we march on, though, we must take stock of where are we now? How would we grade our own performance as defenders of the detrusor? A recent study, 2024, looked at a registry here in the United States, 2,400 providers, 68,000 patients. We have work to do. Basic testing was performed at an alarmingly low rate, 30% PVR, 3% uroflow. Advanced testing was even lower, cystoscopy 3%, multi-channel urodynamics was performed at only 0.1%. If we are to use the preservation of bladder health as our North Star, we must first embrace that BPH drugs are not treating therapies, they are temporizing measures. To be clear, we are not anti-drug. For example, in sepsis, antibiotics are treating. And then similar to brain tumors where medications are temporizing, surgeries are treating, deobstruction for BPO is a mechanical solution for a mechanical problem. This perspective is not something that is evolving just for us, but it's also evolving for our men who are saying no to a drug-first approach. 2/3 are not satisfied, and we see that with low compliance rates. 2/3 want an alternative for multiple reasons: side effects, cost, inconvenience, marginal improvement. And as our brother in arms from the Italian Brigade, Defender Sindolo says, please stop narcotizing bladder. What about the combat trial? Fantastic data. Does a great job of illustrating how well combination drugs can temporize. And we applaud the 66% reduction in risk compared to tamsulosin. And we see that out to 4 years. By inductive reasoning, if we take this out to 10 years, the risk is never truly eliminated. 1 in 10, 1 in 3 men are still at risk for stage 4 retention and surgery. So in effect, BPH drugs are really just sweeping the problem under the rug so we can sidestep the issue until later on when we can deal with it. But by then, the disease has progressed even further. And we see that the negative impact of drugs is there on bladder health. And this classic study from the UK, 303 men who underwent TURP over 2 decades. When we look through the lens of the 5 stages, we can begin to see something emerge. From 1990 to 2010, while men on drugs increased to 43%, surgery decreased by 65%. As a result, in 1990, 2/3 of men were having surgery for the indication of early stage LUTS. And 2 decades later, they were being shifted, progressed now to 2/3 of men having surgery for the indication for late stage 4 retention. Of more concern is a 6-fold increase in long-term failure to void despite deobstruction. And we find similar findings across the Atlantic in Canada. Similar study, 305 men underwent TURP over 2 decades. Once again, look at it through the lens of the 5 stages, and we see something very similar. From 1988 to 2008, while BPH drugs in men rose to 87%, we see that the TURP percentage decreased by 46%. As a result, in 1988, 2/3, once again, were having surgery for the indication of early stage LUTS, and now they are being shifted, astonishingly, to 82% of these men now are presenting with stage 4 and 5. Specifically, almost doubling of stage 4 retention and more than doubling of chronic retention. With this increase in men presenting in later stages, we would hope that the number of prescriptions would be decreasing. Alas, that's not true. At least in this one example in Japan, looking at their database, the alpha blockers, the prescription rate increased by 27%, 5 alpha reductase inhibitors increased by 60% between the years 2014 and 2021. It is time now for us to really fully embrace that BPH medications temporize, they don't treat. As we turn to this nice review of 24 studies, this highlights really that there's a positive correlation between medications and mortality. And we can see that here, where the relative risk of mortality increased by 28% for those on drugs, 5 or more drugs, and that rose to 1.44 relative risk for those with 10 or more drugs. So yes, we need to embrace the fact that BPH drugs are temporizing, not treating. And as a result, we turn to this study here, a nice review of 29 publications, 2024, where they really highlight that a greater surgery is one that has greater symptomatic benefits with greater deobstruction, allowing both patients and bladders to be better. So if greater deobstruction is better, then what is the maximum deobstruction we can offer? The most you can offer is your maximal approach, or is it some fraction thereof, your fractional approach? The Bladder applauds the fact that we have so many tools in our tool belt for both approaches for BPH in this golden era of technology. And it also applauds choosing the right deobstruction, factoring in our trifecta of size, shape, and detrusor function at the table of shared decision-making as we seek compromise when one size does not fit all, when patients want to live their best lives, when bladders want the best health with the maximal approach, when healthcare wants to reduce the large burden of BPH care, and when urologists want at least one technique per approach to offer. Taken together, surgical choice is a two-step process. The right deobstruction, finding that, starts with a binary choice between two approaches, the maximal approach and the fractional approach, where they are weighted differently based on the needs of each individual party. The right data helps us frame the problem from where the bladder sits within the window of curability. No matter the stage, the bladder will always want the maximal deobstruction before the onset of damage or before the damage is irreversible, but is willing to compromise with patients who want the fractional approach to optimize their vitality, physical, intellectual, emotional, social, spiritual, and sexual health, ejaculations, and with urologists who want benefits and the durability of a maximal deobstruction, but recognize they need to balance risk versus reward, and with healthcare systems that want solutions that are appropriate and cost-effective. So this simple binary step leads us to the second fork in the road, which is selecting the right technique based on the available technologies, our expertise, patient preferences and values, as well as an appropriate benefit to risk profile. So we select from these 4 categories based on the selected approach. So if you want a fractional approach, you choose from the least invasive surgical therapies list or the minimally invasive surgical therapies missed. For a maximal approach, you choose from the invasive surgical therapies list or the most invasive. This is a living, patient-facing decision-making aid. These approaches are not mutually exclusive and can be performed sequentially in either direction. These categories are evolving constantly as the technology and the techniques continue to advance. The risk is a reflection of generalized patient perceptions and does require individual customization. The best surgeries are the ones you do best and are the best fit for all 4 parties at the table of shared decision-making. To summarize, choose data over drugs. If you write prescriptions, then triage your patients to get those bladder health baselines so that we can preserve bladder health by intervening at the right time. Make our vision a reality of all of our patients living their best lives chemical-free and catheter-free as we prevent late-stage disease for an organ that cannot be transplanted. So please lean into protecting bladders because you are defenders of the detrusor. Sign up at manvsprostate.com, join the dialogue on LinkedIn, and let's go save more bladders. This concludes what I have to say. I just wish to add that sharing this time to synergize with you is both heartwarming and hopeful, And I look forward to similar interactions frequently in the future.